the 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 real issue, and those are fascinating talks. I learned a lot about the coronaries, and I know that a lot of the structural cases were done yesterday. And I apologize I couldn't join yesterday, but Srinivas asked me to give one lecture and about TAVR and sort of some of the issues. And one of the things I thought I'd discuss is bicuspid valves, because I think it's more of a topic and relevant topic in India, and you see a larger percentage. And as TAVR is growing, I think it's one of the more complicated issues. I'm sorry, I really apologize. Can you hold on 1 second? I apologize. Sorry.
We keep seeing a lot of young patients also being taken up for TAVR in our country. That's how I think we always have a bias and mindset what to decide and which type of patient. In US, what I was told is they are always particular that they won't take up any patient less than 70 generally, maximum up to 65. Go ahead.
Okay. It's not a STEMI, so I'm okay now. Sorry about that. The issue of bicuspid valves, and we've discussed it, and I think, part of the challenge is we don't have a lot of data about TAVR and bicuspid valves, but we also, bicuspid valve is not a single entity. When we're talking about bicuspid valves, we use the term generically, but the reality is there's a lot of heterogeneity in how it presents. And so, I think it's important to really understand the anatomy. And I think over time, we're going to need to get more data. And there's obviously different classifications. And this is the historical classification. We called it type 0 without a raphe, type 1, which has, a single raphe, and type 2 with 2 fused raphes. And with age and with region, the presentation of each of these can change. And so part of the challenge is the TAVR devices are really designed to treat a circular annulus. And bicuspid valves, by their nature, are not circular. They're asymmetric. And I think that becomes one of the challenges. And that can lead to variability in outcomes, not only in acute results in terms of PVL, annular rupture risk, and other factors, but also in terms of long-term results in terms of durability. When valves are asymmetric, they tend to not last as long because the stresses on the leaflets are more abnormal. So when you have a bicuspid valve, you might get an asymmetric deployment and have abnormal leaflet function and early failure. So I think there's a lot of different concerns. And the primary, as I said, is the asymmetric nature of the annulus. When you put a TAVR, the tricuspid valve, you get symmetric expansion, and ideally into all of these commissures. With the bicuspid, you may not get sealing at the commissures, and you can get paravalvular regurgitation and lead to PVL. The heavily calcified raphe, which is common what we see in sort of these type 1 bicuspids, plays an important role as well. And part of the issue is when you do a TAVR and you have this calcified raphe, if it doesn't allow the valve to expand in this direction, you get asymmetric deployment of the valve, and that can cause root injury on this side because you don't have room for the valve to expand. But it can also lead to non-circular deployment. If you have a calcified raphe here, heavy calcium here, you may get an elliptical deployment. This is an example of a sapien valve. You see here, this is one we did a long time ago. But we have a calcified raphe, and you see the valve is a little bit oval. And especially intraannular valves, if you're oval, this leaflet is not functioning because it's not stretching normally. And then there's obviously concomitant pathology with bicuspid valves with aortopathies, and you have to really understand whether those valves, if the aorta needs to be done, that patient should probably have surgery. As I said, there's not a lot of data, but recently this was a large data set from the US from our national registry called the Transcatheter Valve Therapeutics Registry, or TVT Registry. Every case done in the US has to be entered into the registry. And that's part of one of the conditions for reimbursement by our Medicare, which is a national payer. So by definition, they will have the vast majority, 99% of all cases done in the US. And so they took, at this point, this was up to 2018, there were over 90,000 sapien 3 cases in the registry and about 2,700 bicuspid. they matched these bicuspid patients to a similar group of tricuspid with propensity matching, and there are these covariates that were used. And what you saw in general was, overall, the results were good. Device success was high, 96% in both, no difference. Conversion to open surgery was a little bit higher in bicuspid. The annular rupture rate was low, but it was definitely higher in bicuspids. It was 0.3%. And the need for a second valve was a little bit higher in bicuspids. But overall, the results were still pretty good. Now, you look at the other key outcomes, mortality was no different. Strokes were a little bit higher. These are all site reported, but 2.4 versus 1.6. Pacemaker rates were a little bit higher, 9.1 versus 7.5. And these are all important considerations. And when you looked at the 1-year mortality between bicuspid and tricuspid patients, there was no difference at 1 year. Stroke rates were no different at 1 year either. And paravalvular leak, which is one of the important considerations, was not very high. I mean, again, site reported, but the rates of moderate or greater PVL were around 2% or less at 30 days, and no difference between the two groups. And so the vast majority had none trace at 75% roughly. So those were all encouraging results as well. And then hemodynamics, essentially no difference, overlapping one over the other, with the mean gradients of around 10 at 30-day and 1 year follow-up, and valve areas around 1.7. No significant difference between bicuspid and tricuspid. But these analyses have a lot of limitations. There's selection bias. The bicuspid valves that were treated were the ones where the operators felt they could do a good job with TAVR. So it doesn't necessarily include all of the bicuspid valves. And we don't know the patient risk status. We don't know aortopathy status. And then in terms of the results, these are all site reported. There's no core lab. So for instance, PVL especially, we know that physicians in general, when you look at a core lab versus site reported, we're going to underreport our PVL. And there's no CEC to adjudicate outcomes. But it's still a large data set showing that it can be treated. But, I think, one of the important things, this is all still relevant early data with early generation devices. And I think we need to get a better understanding of what bicuspid means for TAVR. The CVRS classification is not the same. It doesn't help us categorize which ones will do well. And I think that's where, there's people have proposed new classification systems, either tricommissural with 3 commissures, or bicommissural without a raphe. I mean, this is essentially the type 0, but this is sort of a spectrum. This is bicommissural with a raphe, calcified raphe. This is the vast majority of patients. And we need to understand how TAVR interacts with these different valve phenotypes, because it's going to be different. The valve will expand differently in this anatomy versus this. I think those are all important considerations. And it's important to understand what is the impact of calcium and heavy calcium. And so this anatomy doesn't have a lot of calcium. There's a lot of fusion, excuse me, a lot of fusion, but not a lot of calcium. Whereas here, you have a lot more calcium. Excuse me. And so the goal with all of these TAVR devices is preventing PVL. And normally with TAVR, when we're talking about PVL, we're talking about sealing at the annulus. You got to seal the valve against the annulus. And we have a chunk of calcium in the LVOT that can affect sealing. But at bicuspid valves, the seal zone may be moved up, and that calcium may not matter, because in a valve like this, the sealing can occur at the leaflets at a much higher level than at the annulus. And basically, to prevent PVL, the skirt of the TAVR device has to cover the seal zone. And in bicuspid valves, the seal zone may be higher, and the valve needs to be deployed higher. And so you got to look at each anatomy and say, where is it going to seal, and what is the size at the level that it's going to seal? Is it at the annulus, or is it higher up at the leaflets? And in a lot of this stuff, this question of this raphe, it doesn't crack, but that was always the concern. What happens if you try and seal up here and then this opens up, then you're going to get leak around it. The reality is these are fused, calcified, and they don't crack. I just want to give you some examples. This is a bicuspid valve with probably a raphe here between the left and right, minimal calcium, and you can see that raphe here, and this would be calcified as a tricommissural with raphe. So in bicuspid valves, I tend to look at the BAV. I generally balloon all of the bicuspid valves because I can see the behavior of the leaflets. I can see the behavior of the balloon. Is it opening easily? Is it opening to one side? What are the concerns? And so in this particular patient, this was an older patient, older trial, Sapien XT, but there was good circumferential expansion of the valve and minimal paravalvular leak and no issues. So this is an anatomy where it's really bicuspid, but these anatomies are ideal for TAVR, and you'll get results comparable to a tricuspid. But there are ones where you may not. And again, I worry a lot when you have this heavy calcium, especially a calcified raphe. And this is a core valve, and you can see at that level of that calcium, the valve is asymmetric. Now with core valve, that's okay. You have supraannular leaflets, and you may still get normal leaflet function, but it can lead to other complications, as I'll show you here. And this is an example of a core valve we did. This was a type 0. And you see here we want to deploy high. And what happens here with bicuspid valves is you can get long leaflets. And the leaflets are long. And if your core valve ends up low, you can get leak through the stent frame. And here at the level of the leaflets, we're very asymmetric. And you see the leaflets opening, but this will impact leaflet durability in my mind. And if you're low, you essentially here, we ended up almost intraannular, so to speak, at the level of leaflet coaptation. And that's why you're getting these asymmetric leaflet opening. And I think that can really impact durability. So we did not, even though there wasn't a lot of leak, we didn't like that. And we decided to post-dilate. And you see with post-dilatation, although it's not perfect, we get much better expansion and more circular. And the mean gradient went from 13 to 5. And so I raise this as an example of, especially in bicuspids, I tend to use TE because I like to understand what my result is. And you need to do a careful interrogation of the valve after deployment. And if I'd gone RAO, I would have seen that valve was under deployed. And even though there's not leak, the post dilatation was for better valve expansion. And the mean gradient was 13 to start, not bad, but with post dilatation, it was 5. So I think you need to do more careful sort of post-deployment assessment of these valves to understand what best to do. And this is an example of extreme. This is presented by Dr. Testa at a GYM meeting in 2019. And this is an example of a heavily calcified valve, calcified left leaflet, non and right fusion with a calcified raphe. And you look at this accurate valve, in one view, you see it expanded, but in the other view, it's not, because it just never opened, doesn't have the radial strength to open. So there are some questions about valve choice and in some of these anatomies. And I think you have to be careful that you don't end up in a scenario like this where now you're stuck and it's going to be really impossible to post-dilate this valve. And this valve may not have the radial strength. So there are certain anatomies that you have to be very cautious of. And this calcified raphe can also cause injury, because when you have a raphe like this, the entire valve is going to deploy over here. It's not going to deploy in the center of the sinus. And when everything gets pushed over here, you can get a contralateral injury. And I think in high-risk anatomies, we look at the root on TE as we deploy. And you see here, this was not a great example. I pulled the wrong slide. But here you'll see it at the end briefly penetrate into the root. And that can be useful. And there are also other unusual risks. And this is a valve with again, non-right fusion, non-calcified raphe, a small left coronary leaflet. The heights to the left main were a little bit low, but not terrible, 11 to 12. But the sinuses were big. They were 34. We chose to do a Bav sizing. This is a 26 millimeter balloon, which we thought we had a waist and a good seal, especially on TE. So we elected to go with a 26 millimeter Sapien valve with sort of a normal position. And you see we end up about 1 or 2 below the annulus here. You see a nice waist here. But immediately after deployment, refractory hypotension, the LV function dropped, patient went into VF, and we had to shock the patient. And you see here again, there's no flow in the left coronary now. And so we've included the left coronary despite a sinus of 34. And you see here, when we inject, the native leaflet is sealing the sinus. We've push the native leaflet up. This white line is the native leaflet, and we've sealed off this sinus and obstructed flow. We get some flow around it when we inject with the catheter, but we've essentially sealed, and that's why the patient arrested. We had to put the patient on ECMO. We wired around that frame, got a stent, and brought that stent back to the STJ and to stent that leaflet open. And the patient recovered and went home. But if you look at what happened in this scenario, normally we'd expect a 26 millimeter S3 to sit like this, and there'd be plenty of room to the left coronary. But because of that calcified raphe, that S3 did not sit there. It got pushed towards the left. It wasn't sitting central. It was sitting over here. And you can see that on deployment. And by doing so, we sealed off the entire left coronary sinus. And so you can imagine here, this sort of left sinus is shorter there, and it's very asymmetric. So this leaflet sealed off this sinus, and that's why we occluded flow. And I think those are important lessons, and you may need to look at that. And so when you're doing transcatheter valve replacement in a bicuspid valve, there's a lot of things that you need to consider. It's not just annular size. It's what is it? Is it a bicommissural or tricommissural? Is there a calcified raphe? Those are all important considerations. And eventually those will be important considerations as we know more about which valve type we choose, whether it's a sapien or a core valve. In the past we used to use Lotus, and Lotus worked really well. And so, I think these are all important considerations. So, and you need to look at root size, is there room? And these are all factors that go into the choice. And bicuspids can be done, but there needs to be a lot more caution. You need to understand how the valve's going to interact with the TAVR device. So I'll stop there. Thanks a lot.
Thank you, Susheel, for an excellent talk with guidelines to deal how the complex anatomy in bicuspid patients. As you do more and more cases like you, and then I think you go into more and more intricacies and learn a lot with asymmetric expansions. I remember when we were doing cases together, the calcium chunk on the other side, and the companies predicted little higher sized valve because of Susheel's expertise. We put it on one size less. That's how it was almost about to rupture, but still stopped. That helps a lot, proper analysis of the CT. And he guided us and made us learn the CT angio, the 3Mensure software. All of us need to become comfortable with 3Mensure software usage. And there are some indigenous softwares also available now, like EndoViz and other things. One thing on this for this iPad users also, Mac users also, there is one other software available freely for us to practice. I think one thing which bothers us is about the age group of this patient, Susheel. What age you are comfortable? What is the lowest age group which you have done in US?
This is all sort of changing. I mean, I think, it's about durability, and there's culturally different issues, and, it's about being open and honest with the patient. If I see it in the U.S., average survival it's changing in the COVID era, which is sort of sad, but average survival I would say is 80. And so if someone is getting a TAVR at 60, I tell them there's a reasonable chance that they're going to need surgery in their lifetime. And it changes depending on, if I have a small person, I can put a 29 millimeter Sapien 3. I know I can comfortably do a valve in valve. But if I have a small person if I have a small annulus, small sinuses, I'm not going to be able to do valve in valve. So that 60-year-old or 65-year-old even is likely going to need surgery. And you can have the conversation with the patient and say, this is the concerns. And if they understand that and they're willing to undertake that risk, that's okay. But I think there has to be a conversation about the unknowns. About durability and the potential impact of that on sort of valve choice and surgery versus TAVR. But I do people in their 60s, but I have a conversation with them.
Yeah, we took your guidelines and I presented, when you're not there, the TAVI registry, what we made in Apollo for the data to be entered. I have mailed you and sent you in WhatsApp. Please, you can see and advise us if any other parameter is missing. So we would add up in for the registry. As we discussed, we are trying to network and make all the TAVIs done in Apollo units to be in one registry and try to come out with some data which is reasonable. I think thank you for all the help and guidance. And any other questions before we close, sir? Dr. Saurabh Banerjee, sir, is very senior expert cardiologist from Kolkata, and many of the very quite interested even at this time is still there. Do you would like to ask anything or?
No, I think it was an excellent presentation, and there was quite a few things we learned. And I would really congratulate Dr. Kodali for taking his time out in spite of a busy schedule and being on the call tonight.
Yeah, sorry about that. No, I apologize. You,
No, that-
you always try to time it. I thought it would be fine, and it never is. So that's my mistake.
No, that shows you give us so much importance. In spite of anybody else would have just canceled the talk and not joined. Thank you very much for your association and great help. And I should say that whatever TAVI cases which you did in Apollo, main Jubilee Hills, is all because of his guidance and expertise. Actually, whatever recently certified us that you are now an independent operator. Once we did one difficult bicuspid valve recently, the latest cath lab. Thank you, Susheel. And if there are no further questions, anybody who has any questions to Susheel, you can feel free. Otherwise,
Susheel,
Yes, please.
so I would like a wonderful talk. Congratulations to you. 2-3 things I wanted to ask. One is that when you're doing bicuspid, do you prefer a self-expanding over balloon expandable? One question. Second is, do you like to post-dilate these patients? And the third thing is, at what position do you like to start deploying? Because, even when we started deploying at 4, it jumped back to 0 position. So these 3 things I would like to know from you.
Sure, absolutely. I don't think there's a great answer about balloon expandable versus self-expanding. I used to like Lotus when it was around, and now it really depends on the anatomy. If it's not a calcified raphe and it's relatively symmetric, I tend to favor balloon expandable, especially if it's a large annulus. But in many of these ones with really calcified raphe and sort of smaller sort of openings, I've been using self-expanding more, but I always pre-dilate. I think the challenge of using a self-expanding in these anatomies is you deploy the valve and it's pancaked. And I think when you deploy valves with these bicuspid valves, it's important to go to the orthogonal view. So, I don't know if your preference is to deploy an LAO, a lot of people do, but it's important to go to that RAO view, because in the RAO view, in the LAO, the valve will look like this, big, but if you go in the RAO view, it looks it's pancaked. And that means that you're not opening. And so if you see that pancaked appearance, I would not deploy the valve. I would recapture, come out, and if you did a balloon, then do a larger balloon, because when that happens and it's pancake like that, several things happen. One, the nose cone might be stuck and you can't get the nose cone out after you deploy the valve, and then 2, ballooning it after, you risk popping out the valve if you do that. So I think for those scenarios, I would be very cautious with self-expanding and really adequately dilate the valve before. Even with balloon expandable valves, I tend to dilate them first because I think in bicuspid valves, unless the angle of the aorta is very vertical. But if the angle of the aorta is horizontal, crossing these can be difficult even with the flex cath. So I will tend to balloon them first, but there's no right choice about which is better or worse. I think you have to just look at each individual anatomy and try and understand, is the valve going to sit and sit appropriately in that valve? The balloon expandable valves have more radial strength, but there are anatomies where with a lot of calcium, there's not room and you risk annular injury. And I think that's the big thing with balloon expandable valves, especially if you have that calcified raphe and the whole valve is going to sit to one side. That's when you get annular injury. And in general, the last question you asked was about positioning. Whether it's self-expanding or balloon expandable, I try to position high. I think one of the things that you had to be cautious, and this was the case Srinivas was just talking about when we were looking at the case that they did. If you size, if you have a bicuspid valve, a lot of people, we try to implant really high and you try to seal at the leaflet tips. Because as you can imagine, if you have a bicuspid valve, if the skirt is at the leaflet tips, you'll get sealing there. And so some people have advocated sizing based on that. And in that case, if you size based on that, it would be a 26. But if you sized on the annulus, it's a 29. The challenge with putting that 26 that high is you have that shoulder, and these leaflets are very restricted. And so, you have the shoulder of this core valve here. And if the leaflets sort of hit there, what they end up doing is they end up pushing the valve a little bit low. And then you get leak through this, because the skirt is only 12 millimeters high or so. So you get leak through the stent frame. And you're not going to seal at the annulus because it's not sized appropriately to the annulus. So in that case, he decided to go with a 29, balloon it 29, seal at the annulus, and got a good result. So there's not a right answer. And I think we need more data, and there is more data that's going to come. But the problem is it's not one entity, and it's trying to understand in the particular anatomy how the valve will sit. In general, though, I would prefer to deploy higher than I would with a tricuspid.